diabetes with CAD managing early as an age. So, as the previous speakers have mentioned, times have changed where managing a diabetic patient used to be only managing glucose levels. And I'm pretty sure all of you as clinicians, whenever a diabetic patient comes to us in our clinics, we don't just look at sugars, but we also have to take care of the comorbid conditions that are prevalent. So let's start with a typical prototype, newly diagnosed diabetic patient who comes with an HbA1c on a higher side, BMI 24, blood pressure on a higher side, LDL cholesterol uncontrolled, history of unstable angina, EGFR OK types on 70 ml per minute per liter, and urinary albumin creatinine ratio of 50. Now, this is a typical case that kind of reflects the maximum number of type 2 diabetics that come and go in our clinics. 2 out of 3 adults with type 2 diabetes will die of CV events, as was mentioned by Dr. Tivaskar, who said that before the patient reaches the end stage renal disease, 50% of them die of cardiovascular events. And hence, we need to look into diabetes, which is also termed as an angina equivalent, because the people with type 2 diabetes are 2 to 3 times more likely to have cardiovascular problems. In India, we all know cardiovascular problem is the leading cause of death, resulting into 28% of deaths in Indian diabetic patients. And amongst these, hypercholesterolemia appears to be the major risk factor for the atherosclerosis that needs to be addressed. And LDL lowering agents to be used primarily as a primary prevention and secondary prevention appears to be one of the major strategies that most of the clinicians follow. Severe risks associated with diabetes and cholesterol are quite known, where CV event rate was linearly related to rising levels of cholesterol and was 4 to 5 times more common in diabetics versus non-diabetics. And hence, combining 2 lectures that I'm supposed to finish in the stipulated 16 minutes now, I'm supposed to present to you how we think about our diabetic patients when they come to us. Apart from the glucose levels that we obviously need to managing the CADs or the cardiovascular problems and dyslipidemia appears to be a co-formulation that we all start in our diabetic patients. So let's begin with the sympathetic overactivity that we see in our diabetic patients that results into the coronary vascular events in our patients. Stress continues to affect Indians. 9 out of 10 Indians are under some kind of stress, although 3 out of 4 would not like to talk about it. 1 out of 2 Indians feel that they don't have sufficient time, and 1 out of 2 are not confident about a lot of issues, including financial terms. And in these last 2.5 years, we have seen a lot of stress being, which was being unmasked because of the COVID pandemic. 62% of our Indian hypertensive patients are sympathetic overactivity, similar to the sympathetic overactivity that Dr. Saraf is undergoing right now because of the delayed time. But I guess definitely know that he is not under stress. And this sympathetic overactivity is driven by diabetes, smoking and obesity as well. What it does to our patient's heart and the cardiovascular system is it causes hypertension, insulin resistance, obesity, all terminating into one of the other coronary events. And the previous symposia on heart failure highlighted the fact that it is, as Dr. Shashank Joshi mentioned, an elephant in the room which is being unmasked, which was always there, but now we are looking more into these heart failure as one of the primary symptoms and an early symptom in our diabetic patients. Diabetes itself causes, it activates the sympathetic nervous system. It results due to the insulin resistance that drives the norepinephrine release, resulting into the non-dippers of blood pressure at night, and an cardiorenal profile, which was also presented in the previous lectures. Essential hypertension and diabetes, when combined, have significant increase in sympathetic activity as compared to those patients who have only hypertension or who are only diabetic, and definitely as compared to those who are not having both. And the symptoms like tremors in hand, fast speech, restlessness, inappropriate sweating continues to be one of the symptoms for most of our diabetic patients. An elevated heart rate increases the risk of CHD mortality by almost 2 times. Elevated heart rate significantly increases the risk of adverse events, as was evident by this beautiful study. The name of the study was Beautiful Study, where a heart rate more than 70 beats per minute had increased risk of cardiovascular death, admission to hospital for heart failure, and admission to the hospital for myocardial infarction. And hence, coming to the management of these this particular comorbid sympathetic overactivity that is associated with not just the stresses in life but also diabetes per se, is the use of beta blockers. We all, when I'm pretty sure 20 years back, our books also mention use of beta blockers way down in the line in our type 2 diabetics, owing to the fact that it masks the hypoglycemic events, and there were also reports of hyperglycemia due to beta blockers, but those were non-selective beta blockers, and over a period of time the guidelines have changed where beta blockers in type 2 diabetics are recommended, especially where heart rate control is a need. Why? Because beta blockers do reduce sympathetic overstimulation, reduced heart rate and cardiac contractility, and hence reduces the oxygen demand. So how do we manage these amongst the beta blockers? The more cardioselective one being metoprolol, which reduces sympathetic overactivity. It is a rapidly and completely absorbed molecule which has a half-life of 3 to 4 years, excreted via hepatic route, no accumulation in your CKD patients, and last but not the least, has no active metabolites. And because of all these mode of actions of metoprolol, it reduces heart rate to the tune of around 14 beats per minute. It reduces risk of all-cause death and sudden cardiac death to the tune of 22% and 30% respectively when compared with diuretic, which was initially or it's still amongst the earlier group of antihypertensives to be used in most of our hypertensive patients. But when it comes to diabetes and hypertension, and when you want a heart rate control to be considered, beta blockers scores way too over. Coming to the sustained release of these molecules that reduces the pill burden, there are 2 types of sustained release molecules that are available. One is a gel-based matrix system, and the other one is a multi-unit pellet system that is based on a zero-order kinetics. What is the difference between the two is that you have each tablet that consists of several hundreds of micro pellets, which are very minute, and it's covered with an insoluble pH-independent polymeric membrane. This results into a slow-release matrix tablets, do not disintegrate, and the entire dose is consequently contained in one single unit, which during the GI transit. This is a graphical representation of the same. What it basically means that it renders the release of drug unresponsive to changes, which are these. It does not change depending on whether you have this tablet pre or post meal. It does not change depending on the pH of the GI system, and it does not change on the basis of effects of agitation. And hence, it is a truly once daily administration for better compliance. The therapeutic plasma concentration is smooth and uniform across 24 hours, higher beta cell selectivity with reduced or lesser side effects, and hence it's better tolerated. So that completes my half of the topic. The other half, which in 9 minutes I'll finish, is the dyslipidemia part. Now, we all know the typical Indian dyslipidemic patient that presents, a diabetic dyslipidemic patient that presents in our clinic, which the prevalence being almost 79%. The patients on statin achieve LDL goal, only half of them achieve goal, and the requirement of other drugs are frequently required for managing our typical diabetic dyslipidemia that also includes hypertriglyceridemia. But amongst all the therapies for the comorbid conditions that we see for our diabetic patient, lipid lowering therapy accounts to more than 70% reduction in the CV risk in our diabetic patients. 1 millimole of reduction of LDL cholesterol, that translates into around 38 milligram percent reduction of LDL cholesterol, reduces major coronary events by 24%, coronary vascularization by 24%, stroke by 15%, vascular deaths by 12%, any deaths by 9%, and effect on major vascular events by 21%, which appears to be quite a significant number if you add up these things. So what do the guidelines say about the management of these cholesterol lowering agents? What they say is, and what we have been practicing in our clinics is, we target LDL cholesterol. All of us are quite aware of the fact that we do look into this LDL cholesterol the moment that a lipid profile comes in our hand, especially in our diabetic patients, the diabetic population. Now, the absolute, rather than the absolute value, what the recommendations are, reduction to the tune of 50% of what the present values are. Although the specific values also need to be taken into consideration depending on, according to the risk scoring system where the patient falls into. A diabetic patient with or without dyslipidemia, as I told you, that diabetes per se is known as an angina risk equivalent, and hence a diabetic patient is categorized into high risk or very high risk category, whether the patient's rest of the scoring systems makes him either high or low, moderate risk person. So presence of diabetes per se puts the patient in a high risk category. Why are we discussing these risk categorization? The reason being that all the guidelines dictate the doses to be given of these molecules on the basis of where the patient falls into, or which risk category the patient falls into. If triglyceridemia is concerned, which is seen quite so common in our Indian population owing to the diet that we all consume, the drug treatments for hypertriglyceridemia also suggest use of statin as a first line drug, and increasing the dose of statin over rather than adding another drug. So statin therapy should be considered before introduction of a combination therapy, and intensification of the same should be considered. Why? Because when you reduce the LDL cholesterol by 50% of the absolute value that you initially got in your patient, it reduces the event rate by 57%. Cardiovascular event reduces significantly, as you can see, depending on the rate, depending on the reduction of LDL cholesterol. And again, what does this moderate intensity or high intensity statin therapy which is recommended, what does it mean? A high intensity statin that is recommended for almost all the diabetic patients is on an average a rosuvastatin of 20 to 40 milligram or an atorvastatin of 40 to 80 milligram, as against those who are categorized as a moderate risk and are put on moderate or reduced risk are advised moderate intensity statin, which is the doses are as mentioned, rosuvastatin around 5 to 10, atorva around 10 to 20, and the rest as is shown. So now narrowing down, so one thing is sure, we need to give statin to almost all our diabetic patients. It does benefit, right? Now, which statin to be given? There are different studies that head to it compared atorvastatin versus rosuvastatin, where it's quite clear where rosuvastatin scores over atorvastatin in terms of reduction of LDL cholesterol, the ratio, and the non-HDL cholesterol. There is the percentage of patients achieving this goal within 4 weeks was way too higher with rosuvastatin as compared to atorvastatin. Rosuvastatin also scored better in your pre-diabetic patients and even in your non-diabetic patients, where it did show reduction in the cumulative incidence or the primary endpoints to the tune of 31 and 49% respectively. If you compare the previous drugs, simvastatin with atorva and rosuvastatin, in this meta-analysis of almost 32,000 patients, where amongst them the high-risk population were around 21,000 patients, rosuvastatin scored way too higher as compared to atorvastatin and simvastatin in getting down or reaching the optimum level of LDL cholesterol, with the doses of around 10 to, on an average 10 to 20 milligram of rosuvastatin. Greater reduction of LDL cholesterol was seen with rosuvastatin as compared to atorvastatin in all these studies, like your Uranus, Andromeda, and the Coral studies. Coming to the innovator versus the generic brands, very well explained by Dr. Mangesh Tivaskar, and the efforts that are put in by the innovator brands. If you read across the guidelines for the generic brands, there is a discrepancy of around 20 to 25%, where there is a kind of a balance between the increased side effect versus the reduced drug efficacy. And because of the presence of these methylated impurities which are prevalent in our generic drugs, there is a lot of interference over the effects of these drugs, and hence it is seen to have reduced effect on the HMG-CoA inhibitor enzymes. There was a study in Spain that compared an innovator brand with a generic brand that showed improved risk of cardiovascular events on those patients who were on generic drugs to the tune of 31%, which is again quite a significant number. The stability of an innovator research rosuvastatin formulation is significant, owing to the impurities like your lactone, antiisomers, and 5-keto acids that can be formed during or after the production of the tablet, and these do impact the stability of the rosuvastatin. So, coming back to our the prototype patient that I presented right in the first slide, we do know that diabetes do present with sympathetic overactivity and a typical dyslipidemic profile that we see in our day-to-day patients. These need to be addressed. Sympathetic overactivity can be managed with a once-a-day metoprolol, and dyslipidemia is, and we have all been using a statin, and amongst the statin, rosuvastatin scores above the rest. Thank you.